afternoon, everyone. Let me present myself first. I'm Soukaina, a PhD student under supervision of Professor Brahim Admou in my second year. Today's talk is going to be about primary immunodeficiency exploring, experience of the Laboratory of Immunology, University Hospital of Marrakech. To introduce, primary immunodeficiencies result from genetic mutations altering the function and are mainly raised in front of particular clinical manifestations. These clinical manifestations are dominated by repeated, unusual, persistent, or rebellious infections and the failure to thrive in some cases. Immunologic investigation is based on multiple tests and done successively, starting from immunoglobulin assessment, flow cytometry, neutrophils function assessment, cytokine assays, and complement assay. In this study, we are going to report the experience of immunology laboratory at the University Hospital of Marrakech. The population of interest, which is the pediatric population, was divided in two groups. The first one was cases of primary immunodeficiency suspicion, while the second one was cases of complement and immunoglobulin deficiency suspicion. The first group underwent flow cytometry using TBNK immunophenotyping, phagoburst test, HLA-DR assessment, while the second one underwent nephelometry in order to assess immunoglobulins deficiency and complement deficiency as well. TBNK immunophenotyping was done using flow cytometry, as we just saw. It consists of multiple steps of staining, incubating, lysing, and then analysis. After TBNK immunophenotyping, lymphocyte subpopulations are done. A different software will be used to identify specific cellular markers. For example, the HLA-DR expression and the T lymphocytes activation. For the HLA-DR expression, that is mainly assessed on lymphocytes and B lymphocytes, seeing that these populations express the HLA-DR constitutively. We technically did the same steps, just like previously: staining, incubation, lysing, and then incubation, and acquiring and analysis. While for the T lymphocytes activation, there are additional steps of activation, stimulation, fixation, permeabilization in order to see the cytoplasmic components. And then after the multiple cycles of washing, and then we acquired the samples and analyzed the data. For phagocyte function assessment, we used the phagoburst test or the HLA-DR test, the DHR test. It consists of multiple steps. First of all, the activation step with the opsonized E. coli bacteria, PMA and FMLP. The second one was the oxidation step, where we add the substrate solution. The third one was the lysing and fixation. And the fourth one, washing and DNA staining. And finally, samples are ready for FACS analysis. After sample analysis, using BDFACS DIVA software, data were interpreted accordingly to determine if it's about an X-linked or an autosomic recessive form of chronic granulomatous disease. Nephelometry was used as well to assess complement deficiencies and immunoglobulin deficiency. This test is normally automated, but the principle is based on measurement of optical density that is done after light is scattered by soluble immune complexes, as you can see here. And the concentration of antigen is directly related to the amount of light scattered and detected by detectors. Our results, after conducting all these tests, we had two main groups of primary immunodeficiencies. The first one, cellular deficiency cases, where we had 9 cases of severe combined immunodeficiencies, 4 cases of combined immunodeficiencies, 1 case of HLA-2 deficiency, and 2 cases of chronic granulomatous disease. While the other group, which is the humoral deficiency cases, we had 1 case of hyper-IgM and 7 cases of IgA deficiency, 5 cases of complement deficiency, and 2 cases of C inhibitory deficiency. The results, In order to identify severe combined immunodeficiencies, we mainly studied the immunophenotype profile that was provided by the TBNK test. For example, when we have a T minus B plus NK minus profile, it suggests a gamma chain deficiency. And the T minus B plus NK plus, for example, suggests an interleukin 7R alpha deficiency, while T minus B minus NK plus, for example, suggests RAG1, RAG2 deficiencies. And only 2 cases among all these cases was confirmed with an ADA deficiency, showing the T minus B minus NK minus immunophenotype. The combined immunodeficiency cases was as well determined just like in the previous cases. T plus B minus NK minus suggests DOC deficiency, and T plus B minus, for example, NK plus, they suggest interleukin 21 deficiency. While we had the chance only to confirm 1 case, CD4 minus B plus NK plus, with an HLA2 deficiency. This is the case of the HLA-DR deficiency. As you can see, there are no HLA-DR markers that were present on B lymphocytes nor on monocyte population. When it comes to chronic granulomatous disease, we had 2 cases of X-linked chronic granulomatous disease and 1 case of autosomic recessive chronic granulomatous disease. And these cases were determined using the Fagober's test. And we should also note that in order to differentiate between the X-linked form and the autosomic recessive, we also had access to the mom's blood sample in order to see if we have two curves, then it's an X-linked. If not, it's an autosomic recessive. In this case, as you can see here on the plots, we have the E. coli stimulation, FMLP stimulation, and this is the PMA stimulation. And we did the same for the 4th-month-old male presenting the autosomic recessive chronic granulomatous disease. That's the E. coli stimulation, the FMLP stimulation, and PMA stimulation. When it comes to humoral deficiencies, as I just said, we have 1 case of hyper-IgM syndrome and 7 cases of IgA deficiencies. For complement deficiency, we had 4 cases of isolated C3 deficiency and 1 case of C3-C4 deficiency, while we had 2 cases of C1 inhibitor deficiency. To summarize, our study had shown 2 main categories of primary immunodeficiency. The first one was cellular deficiencies that is divided into 4 subgroups. The first one, severe combined deficiencies, with a rate of 13.43%, combined immunodeficiency 6%, chronic granulomatous disease 2.9%, HLI2 deficiency 1.5%. While the other group, that is this one of humoral deficiencies, we had 7% of IgA deficiency, 5% of complement deficiency, 1.5% of both C inhibitory deficiency and hyper-IgM syndrome. Several studies were done in this field. As we can see in Morocco, it's a 15 years study. It shows as well the rate of 8.74% of SCID cases, yes. And in Tunisia, there was a high rate as well on SCID cases and SCID and KID cases, both with a rate of 28.6%. The same case was noticed as well in Egypt, 41% of severe combined deficiencies and combined deficiencies. The same thing as well in Europe, and in Turkey it was the opposite, low rates of severe combined deficiencies and a high rate of IgA deficiency. To conclude, Primary immunodeficiencies are a heterogeneous group of hereditary diseases that are difficult to diagnose, and flow cytometry plays a major role in the identification of these diseases, and so further tests and more panels should be added in order to explore more PIDs, such as defects of innate immunity, antibody deficiencies. Nevertheless, the accurate determination of these PID cases requires a narrow collaboration between physicians and biologists to establish the diagnosis, especially with adult primary immunodeficiencies. And thank you for your attention.